Hello, Clinic Review family. Today we're talking about obsessive compulsive disorder. It can be found in the blue book. I'm pointing to the blue book there over my shoulder if you don't know what I'm doing. And you can get the blue book at Amazon. I'm going to be doing a little teaching today. I don't usually do that. Usually I just do questions, but I'm going to do a little teaching about obsessive compulsive disorder. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. You know that this channel is part of the greater Clinic Review organization. Mark Klimek founded Clinic Reviews about 40 years ago, and he is the most amazing Nclex reviewer in the entire universe, in my opinion. I've known him for a very long time. He was actually my college professor, and I live down the road from him, down the road, Ohio, down the road. Probably not down the road, California down the road, but I live down the road from him, and he really has a phenomenal outlook. He sees the world in patterns, and so he teaches test prep from the mindset of seeing the pattern. And once he reveals the pattern to us, then we are able to remember the content and understand how to answer the questions. So I do not teach anything here on this channel that he teaches in his big 21-hour NCLEX review. I highly recommend the online on-demand review. And you can find that if you go to clinicreviews.com and just click, I think it's an on-demand tab or something like that. And you can do that. We also do small group tutoring. It's a monthly fee. I do 2 of the tutorings. I do the next gen tutorings, which is why I don't have a lot of next gen on this channel, because we do offer it for a fee through Clinic Reviews. And then we also have our streaming service. So, all right. So let me talk a little bit about obsessive compulsive disorder. So at its base, obsessive compulsive disorder is really an anxiety disorder. So anxiety disorder is not just worrying too much about things. Okay. Anxiety disorder is an inability to control your thoughts such that whatever it is you're anxious about, you spiral down to the worst possible outcome, even if rationally you know that that outcome is unlikely. You can't stop yourself from spiraling down to that outcome and to become obsessed with that outcome happening. For people who don't have obsessive compulsive disorder, they just have anxiety disorder. That anxiety is manifested often with crying, panic attacks, pacing, maybe tremors, sometimes chest pain. So that may be how that manifests. And but with obsessive compulsive disorder, it is an anxiety disorder, but it manifests with these compulsions. So the obsession is that obsessive thoughts. And anxiety disorder is an obsessive thought, right? So if I think maybe my husband comes home, has been coming home late from work, and I know that he's been coming home late from work for a reason. I've been there to see him at work. I know all of his colleagues, but I can't get over the idea that he's having an affair, and I'm absolutely obsessed. So anytime he gets home even 5 minutes late, I'm obsessed with this idea that he's having an affair. And every time he walks in the door, I attack him and I say, "Why are you late? I know you're late." Even if rationally I know that it's unlikely, and he lets me look through his phone and he does all these things to alleviate my anxiety, but I can't get over the idea that he's having an affair. That's an obsessive thought. Okay, that is an obsessive thought. That requires intervention. With OCD, the obsessive thought is manifested by a compulsive behavior. So like if I'm afraid, I have this obsessive thought that if I don't lock the front door before I go to bed, that someone's going to break in and kill my kids. That's the obsessive thought. The compulsion, instead of talking about it all the time and saying, complaining about it and worrying about it verbally, I compulsively get up time and time and time again. And maybe I check the lock 100 times to make sure it's really locked. That's the compulsive behavior. So you have the obsessive thought, the anxiety is treated with the compulsive behavior. So compulsive behavior is our sort of our self-medication for that anxious obsessive thought. And so usually anxiety disorder is treated with a cognitive behavioral disorder, cognitive behavioral therapy. Very seldom is anxiety treated with medication. It can be treated with medication. I'm not saying it never is, but it's often treated with cognitive behavioral therapy. One of the types of cognitive behavioral therapy is to be exposed. It's like an exposure therapy. You're exposed to the obsessive thought, and then you're not allowed to engage in the compulsive behavior, and then you kind of wait and see what happens. And it's very controlled. It's not like you send people home and go, you don't say, okay, you're afraid someone's going to break in, just don't lock the door tonight. No, it's done in a very controlled environment. Often the therapist is there working through it with them, and they're talking through how they're feeling. Okay, you didn't check the lock again. You checked the lock twice. Now let's sit in the living room. You didn't check the lock again. How are you feeling? How does that make you feel? What are you thinking about? Let's see if we can get you out of this thought spiral. Okay. And so that's obsessive compulsive behavior. What you don't want to do is, as the nurse, you don't just go in and just stop them from their behavior. Maybe they're afraid of germs and they're washing their hands over and over again. You don't just go in and say, stop washing your hands. Okay. That's not therapeutic. As nurses, what we do is we try to negotiate a care plan where the care plan is, say, you're going to wash your hands. Normally you wash your hands 15 times. Maybe they also have an obsessive thought about 15 times is the number of times. So you may say, okay, this time you're only going to wash your hands 13 times. And let's try doing 13 times for a few days. And then we're going to move it to 11 times. Okay, let's do it 11 times and see how that kind of pans out, right? So that is sort of a negotiated intervention with us as nurses. We can recommend cognitive behavioral therapy. We can recommend exposure therapy. We may be preparing people for CBT or exposure therapy. We don't actually do it ourselves, but we do implement the care plan, and we negotiate that care plan with people. And maybe we talk about reducing the compulsive behavior over time. So it's difficult to deal with the obsessive thought. So what you have to do is deal with the compulsive behavior. And over time, as they reduce the amount of times they do the compulsive behavior, hopefully their mindset is going to go, okay, I didn't do it 15 times, only did 11 times and nothing bad happened. All right, let's see if we can take it down to 9 now. Do it just 9 times. And then, okay, I've been doing it 9 times and nothing bad happened. All right, let's see if we can reduce it to 7. So that's sort of an example of like developing a care plan in relationship with the patient and talking about that. Okay, so that's just sort of big picture obsessive compulsive disorder. So let's go ahead and do a few. Oh, one other thing that's in the blue book that I want to mention. He talks about the difference between psychosis and neuroticism, psychotic and neurotic. Neurotic is this obsessive thought that you can't get rid of. Okay, that's neurotic, even if you know the thought's not real. So if I don't check the lock, someone's going to break in and kill us all, even though we know in our mind that that's not going to happen. Like rationally, we go, yeah, that's not going to happen, but I can't stop thinking about it. And because I'm so anxious thinking about it, it relieves my anxiety to just go check it one more time. Just, I know it's not going to happen, but let's just let me check it one more time. Right. And then that relieves our anxiety. So that's neurosis. Psychosis, or being psychotic, is when you believe the thing that you're telling yourself. So I say, if I don't check the lock, someone's going to kill us. And you go, do you really believe that? Oh yeah, I really believe that. Okay. Nobody has ever had a break-in on your street in like 50 years. No one's ever been killed on the street you live in in 50 years. And so do you really think that's likely to happen? Oh yeah, I know there's people out there who are coming for me. They're coming for me. I know they are. If I don't check this lock, then yeah, they're coming for me. I'm going to have to, in fact, I may have to board up all the windows too, because like they're really coming for me. There's people out there who are really coming for me. See, that's psychosis. That's psychotic. That's a belief, a false belief. Neurosis is when I know it's not really true, but my anxiety, my spiraling of the thoughts, that's what anxiety disorder is. It's not just normal worrying, y'all. Okay. It's not like, oh, I'm worried about my child. I should send them off to college. I'm worried about them. Okay. That's normal. That's normal. Like we worry about our kids when they go somewhere without us. Like that's normal. But Neurosis or obsessive thoughts is when I can't stop thinking about them and I obsessively call them 25 times a day or 50 times a day or 100 times a day because are you okay? Did anything happen? Right? I just keep calling them over and over again to check on them. That's neurosis. That's an obsessive thought. And then the compulsion would be constantly calling them. Okay. So that's the difference between being neurotic and psychotic. It's the belief in what you're thinking. I believe what I'm thinking is true versus no, I know I'm kind of having these crazy thoughts, but I can't get rid of them. Okay, a client with OCD is performing repetitive hand washing. The nurse interprets this behavior as primarily which of the following: an attempt to avoid contamination, a method to reduce anxiety, a sign of attention-seeking behavior, a form of self-harm. Y'all, it's a method to reduce anxiety. The compulsion eases the anxious, obsessive thought that I'm having that something's going to happen, that if I don't do this thing, this is going to happen. Even though I know it's kind of crazy talk, like it's sort of crazy, but I can't, I have to do it. I have to do it. You got to let me do it, or I can't handle that. A nurse is caring for a patient with OCD who repeatedly checks the door lock. What should the nurse's initial approach be? Lock the door for the patient to reduce the compulsion. Okay, don't do that. That doesn't help them. No, absolutely not. Discuss the irrationality of the behavior. Maybe. Acknowledge the distress without reinforcing the compulsion. Okay. Initial. Okay. What should the nurse's initial approach be? So for someone who has really either psychosis or neurosis, they're both very distressed, and it is okay to acknowledge the feeling. So I understand that you're checking that door a lot. Like you must be feeling very anxious. I can tell you're anxious. So don't say, I can tell you're really worried the door's not locked. Like you don't need to say, you're not reinforcing the compulsion. You're just like, I can tell you're feeling anxious. Ignore the behavior to extinguish it. If that worked, it would work for everybody. Y'all know that doesn't work. A client with OCD is prescribed fluoxetine. What should the nurse monitor closely? So they can be prescribed certain antidepressants, can be used for obsessive compulsive behavior and types of really extreme anxiety. You can use some, I think that fluoxetine is an SSRI. There's also SNRI, selective norepinephrine reuptake inhibitors. So those are some meds. It's not our decision whether they're prescribed. They just can be. So this is fine. What should the nurse monitor closely? So there's side effects and adverse effects. We always monitor closely for the adverse effects because side effects are expected and we manage side effects. Okay, but we monitor for adverse effects. We might need to stop the medication or do something, call the healthcare provider if we notice one of these adverse effects. So blood pressure changes. So antidepressants, really all psych meds are known to lower blood pressure. That's a side effect. So we watch for it, but we don't have to monitor closely for it. Weight gain. All psych drugs cause weight gain. That's a side effect. So A and B are side effects. Suicidal ideation. Okay. The first 2 weeks of taking an antidepressant is their highest time of risk for suicide because the fatigue gets better. So often there's a lot of fatigue associated with depression and anxiety and obsessive thoughts. And so the fatigue starts to improve, but their thinking doesn't. If they'd been thinking about ending their life, suddenly they have the energy to do it. So suicidal ideation is something you always have to watch for after somebody starts on an antidepressant. Urine output should not change. I don't have to monitor that closely. It has nothing to do with antidepressants. So A and B are side effects. We teach the patient about them. Maybe I would say stand up slowly after starting this medication. Maybe I'd say you need to expect to maybe gain some weight, maybe 5-10 pounds. But what I say is, okay, I need to watch for C because C is a safety issue. When caring for a patient with OCD, which nursing intervention promotes autonomy? Encouraging the patient to make decisions about their treatment plan, performing the rituals for the patient, deciding on a daily schedule for the patient, setting strict rules about when rituals can occur. So this is really an autonomy question. This really doesn't have anything to do with OCD. It has everything to do with autonomy. Autonomy is a person's right to make their own decisions or decide what happens in their own life, right? The autonomy. The only time we lose our autonomy is when we're at risk to harm ourselves or harm others. And that's when we get put, say, on a 48-hour, we can be put on a 48-hour emergency hold if we're at such high risk to harm ourselves or harm others. Then we can be. But even then, we don't lose our autonomy 100%. Now, you will lose your autonomy 100% if you actually harm someone else. You get put in prison. You lose a lot of civil rights when people are put in prison, because the idea is that once you've actually committed this harm to someone else, you no longer have the right to autonomy and some other things. All right, that's a totally different discussion. So really this question is about autonomy. So I have to pick the answer that shows I know what autonomy means. Encourage the patient to make decisions about their treatment plan. That's what autonomy is. That's what it is. Performing the rituals for the patient, that has not, no, that's like the opposite of autonomy. Deciding on a daily schedule for the patient, no, that's the opposite of autonomy. Setting strict rules about when rituals can occur, that's the opposite of autonomy, y'all. So A is the only one that is actually encouraging the patient to make their own decisions and be engaged in their treatment plan. Which of these outcomes would be most indicative of successful treatment in a patient with OCD? The patient no longer has any obsessive thoughts. Which of these outcomes would be most indicative of successful treatment of a patient with OCD? I don't know if that's realistic to have no more obsessive thoughts. One of the rules I have is that if I'm not sure, I don't pick the answer with extreme language, and to have no longer have any obsessive thoughts seems a little extreme. So I'm going to put a really big question mark next to it. The patient can go longer periods without performing compulsions. Oh, what would be the most indicative? That definitely would indicate success. B would indicate success, because they may still be having their obsessive thoughts, but they can go longer without doing their compulsions. The patient feels no anxiety at all. That's not realistic. The patient can perform rituals faster. Well, no. It's just, we want to like stop. We don't want them to be doing these compulsive behaviors, or at least reduce the number of times they do the compulsive behaviors, right? So no, that C and D are not correct. A is, it's just not realistic. B is a realistic outcome that I can have for my patients. What is the priority nursing intervention for a patient with OCD who is about to undergo ERP therapy? So I'm sorry for the abbreviation. ERP is that exposure therapy, where we expose them to the obsessive anxiety producing thought without performing the compulsion. Again, it's supervised and so forth. So this isn't the kind of thing where you just throw them to the wolves and go try it, right? It's a supervised kind of a thing. All right. What is the priority nursing intervention for a patient with OCD who's about to undergo ERP? Ensuring the patient understands the process and consents, preparing medications to manage potential panic attacks, setting up a safe environment for the patient, documenting baseline compulsive behaviors. Okay, so all those things seem like they would be important for a patient who's about to undergo ERP therapy. So the question is, what's the priority? And it's not a first question, it's a priority question. It's a best question. So I don't do this very often, but I'm going to talk with you about how to answer best questions. You know, it's a best question when it's asking what's the best priority in nursing action or nursing intervention. So best questions are always about a nursing action or a nursing intervention. Say what's best. So what you do, well, first I say, is there anything I can cross off? I would say probably B is not my priority, preparing medications to manage potential panic attacks. That doesn't seem like my priority. I mean, I'd want to do it, but I can't imagine that's the priority. And documenting baseline compulsive behaviors, that's nice to do, but I can't imagine that's my priority. So I'm going to cross off B and D. They seem nice, but they don't seem like priorities. So for me, it's between A and C. Ensuring they understand the process and consents, because I have to do that for everybody whenever because this is an anxiety provoking therapy. Like they are going to become highly anxious during this. Okay. So they need to understand the process, or setting up a safe environment. Like that's always a high priority, right? So what you have to do when you get it down to 2, which is what people always tell me, they get it down to 2 and then they can't decide. You have to say, this is with a best question only, best only. You say, I would do one, but never do the other, or I would do this one, but never do. So I do A, but never do C, or I would do C, but never do A. So A, and I would ensure the patient understands the process and consents, but not set up a safe environment. Or I would set up a safe environment, but not ensure the patient understands the process and consents. like C seems super important, but I have to ensure the patient understands the process of consents, don't I? Isn't that like something I can't do anything with my patient, like, until I know who they are. I have to do 2 patient identifiers. I have to make sure they consent, that they have an informed consent, that they understand what's happening. Like, I have to do that, right? I mean, I really need to set up a safe environment, but I have to make sure they understand it. So, when you do that, when you go, "Well, I would do one, but not or never do the other one," and when I say never, I mean, you're not doing it later, you're just not doing it. Okay, so this isn't a first question. It's not like I'm going to ensure they understand the consents and then set up a safe environment. It's not that. It's I'm going to ensure they understand, but not set up a safe environment, or I'm going to set up a safe environment, but not make sure they understand. That, to me at least, that is makes it so much more obvious that I have to make sure they understand it. A patient with OCD says, I must check the stove 20 times before I leave, or something terrible will happen. Okay, so their obsessive thought is that if they don't check the stove, something terrible would happen. So then their compulsion is they check the stove 20 times. Which response by the nurse shows understanding of OCD? That's not true. Nothing bad will happen. Okay, so that's just rejecting what they're saying. That doesn't seem very therapeutic to me. I don't know. So I'll come back to it if I don't find anything else, but that does not seem therapeutic to me. Let's check it together just once to show you it's safe. So just using my common sense, that doesn't seem like that would help, because their compulsion is to check it 20 times. If they could check it just once, they would have just checked it once. So me going with them to check it once doesn't seem like that's going to help. Like their compulsion is to check it 20 times. And a lot of times the compulsion is like very specific like that. Like sometimes there's something about a number that they really have to do it a certain number of times. So I don't see how B would help. That's not logical, right? Yeah, they probably know that. They probably know that. I guess I could say it. That's not logical. It doesn't seem very therapeutic. I understand this feels necessary, but let's work on reducing that number. Okay, I like that. So you're acknowledging the feeling, and then engaging them in how to problem solve through how to deal with this, right? Let's work on reducing that number. I like that answer. That's a really, really good answer. Which symptom would the nurse expect to see first? Which symptom would the nurse expect to see first decrease? That wording is weird. With effective treatment of OCD. So what would you expect to see decrease first? I think the first should come after decrease. Which symptom would the nurse expect to see decrease first with effective treatment? So I would expect obsessive thoughts to decrease first, compulsive behaviors to decrease first, general anxiety to decrease first, or depression. I'm going to cross off depression because it's not primarily a depression problem. General anxiety, it is an anxiety disorder, but general anxiety is not what's going to be reduced first. In fact, I would think that anxiety might go up a little bit with treatment. Initially, it might go up a little bit because what we're doing is reducing the number of compulsive behaviors. So the anxiety actually may go up initially. So is it the obsessive thoughts or the compulsive behaviors? So what we're doing is reducing the compulsive behaviors first, and then saying, hey, do you see how the obsessive thought? So you're thinking, if you don't do this, if you don't do A, then B will happen. But you see, you don't do A and B doesn't happen. So it's the compulsive behavior that we're working on first. Okay. Well, I enjoy talking about psych stuff. So I like talking about things like this. I hope you enjoyed it. I find it really fascinating. I have trouble having the patience to work with people with major psychiatric disorders, just because I think I'm a little bit too impatient for that. That's not a good thing. I'm not saying that's a good thing. I'm just saying that I know myself, right? But I do enjoy learning about it. I enjoy talking about it. So I hope that was helpful to you if you get an OCD question or you just want to know more about OCD. So thank you for being a part of the Clinic Review family. Have a great rest of your day.